Hi, everyone, and welcome to the Center for Fibroid Care. Today, the team is talking about fibroids and fertility, and I'm very excited to introduce our agenda for this webinar. I'm Dr. Tara Shirazian. I'm the director for the Center for Fibroid Care. Today, you'll be hearing from Dr. DeVore, our reproductive endocrinologist, who will speak to fibroids and fertility. Dr. Chan, minimally invasive surgery, talking about types of fibroids. Dr. Kossel, who will talk about types of myomectomy. And Dr. Morris, who will talk about interventional radiology and the uterine artery embolization procedure. So first, I'd like to introduce Dr. DeVore.
Hello, I am Dr. Shannon DeVore. I'm a reproductive endocrinology and infertility specialist. So I work with the Fibroid Center for patients who are seeking to preserve their fertility or are having difficulty getting pregnant. So just as a general background, it gets harder to get pregnant as we get older. And that's because we are born with all the eggs that we will ever have, and the quantity and quality decline throughout the reproductive lifespan. So it gets harder to get pregnant as we get older because the number of eggs and the quality of those eggs go down. For most women, the start of the steepest decline occurs at 37. That can, be shifted left or right in some instances, but by and large, that's when things start to really accelerate. You can go to the next slide. So one way that we get a sense of the number of eggs you have left is an AMH level. So AMH is short for anti-Müllerian hormone. It's a hormone that's made by all the eggs left in your ovaries. So more eggs, higher number, fewer eggs, lower number. And we'll see where you fall relative to your peers. This does not tell me anything about your fertility or your ability to get pregnant, but it gives me an overall sense of the numbers. The other reason it's harder to get pregnant as we get older is just the quality of the eggs go down. So the percentage of embryos that are genetically normal and capable of producing a pregnancy decreases as we get older. This is our data over a few years, which is why it goes up and down, but you can see extrapolated to the population, it follows the dotted line. And really, again, where we start to see that more significant decline is at 37. So this is just a pictorial representation of how natural conception works. This is the ovary right here, and from the ovary an egg is released each month. That's ovulation. And if you have open tubes and everything and a male partner, then the sperm would be there waiting for the egg at ovulation. Fertilization would occur on day 1. And then the embryo would grow and develop as it moves down the fallopian tube and implants into the uterus. And that can it's about a week process for it to reach the final resting spot in the uterus. And if it's a healthy embryo and the uterine environment is able to receive the embryo, then it will implant. Fibroids can impact fertility in numerous ways. There are multiple different locations for fibroids to occur. Typically, the ones that are of least concern are the ones that are kind of hanging off the uterus, or either pedunculated, meaning they have a small stalk, or subserosal, so toward the outside of the uterus. Anything that is in or near the cavity can have implications for trying to get pregnant. And so the cavity refers to the endometrium where the embryo would implant and the baby will grow. So that can be a submucous fibroid, which is inside the cavity entirely, or it can be an intramural fibroid, which is impinging on the cavity, meaning it's kind of creating a dent in the cavity that is altering and distorting the anatomy. Further, some fibroids, even if they're not a problem and not impinging on the cavity, they could be blocking the tube. So the location in which they are could prevent an egg and a sperm from meeting because it could be just growing kind of over the entry point of the tube. So there's many different ways that fibroids impact fertility. In terms of women who are seeking to become pregnant and we need to do IVF in order to get eggs, or if we were doing fertility preservation, freezing embryos or eggs, I'll speak more to that on the next slide. So IVF and egg freezing and embryo freezing are all the same process. What we are doing is we are stimulating the entire team of eggs for the month. Your ovary has a vault of eggs located inside the ovarian cortex. And each month, a team of them come out and have been primed to grow and develop over the preceding few months. Your brain then releases a hormone called FSH, which picks one of them at random to grow and develop even further. That one will ovulate, and then the rest die. So with ovarian stimulation, we are giving you that same hormone that's naturally released by your brain, but in higher quantities to drive the development of the entire team of eggs rather than just the one. And so we are stimulating that whole group and team to grow and develop. So the way we do that is you come in on day 2 of your period for blood work and ultrasound, and we begin injections that day. So you take those injections at home every day, and then you come in every few days for blood work and ultrasound. And what we're doing is we're monitoring to see how the eggs are growing and developing, and I'm adjusting your medication dose as needed. It's typically about a 12-day process from start to finish. Most women do pretty well with this process. Bloating and fatigue are the most common complaints, and you can't do any high-impact exercise. For the egg retrieval, if you could go to the next slide, you're completely asleep for that. So we go in with a transvaginal ultrasound, and there's this tiny needle attached. We go from the vagina into the ovary, and we drain all the fluid, which contains the eggs. This is the ovary with the enlarged team of eggs. We drain all that fluid, pass that off to the embryologist, and you wake up with an egg count. Sometimes with fibroids, it can be a little bit tricky to see the ovary. So this is what an ovary looks like on the ultrasound. And if there's a big fibroid that's causing shadowing over it, it can be a little bit difficult to get that needle in the right spot to drain all the eggs. So depending on the situation, there might be some cases where I ask the fibroid center team if we could do a myomectomy to have those fibroids removed prior to the egg retrieval, so that I can more, aptly visualize the ovaries and make sure that we're safely retrieving all of the eggs. If you could go back to the other slide, the previous one, that would be great. So for the eggs, this is what an egg looks like under the microscope. If you're freezing them as eggs, they're frozen that day. If you are making embryos, then we mix the eggs and the sperm together, and we grow them in the lab until they're this advanced stage embryo that's capable of producing a pregnancy. It's about a week process, and this is the stage that we can genetically test, and we can keep them frozen as genetically tested embryos indefinitely. We have babies born after 14 years of freezing, and the length of time that they're frozen does not impact the outcome. So this is all a really great option if you would like to preserve your fertility or if you're having a lot of difficulty getting pregnant. But there are other options that we can do if you're trying to get pregnant and you don't necessarily need IVF yet. So things like an intrauterine insemination, or even helping, ovulation induction with just medications and natural cycle monitoring as well. I believe those are all my slides.
Hi, my name is Elizabeth Morris, and I'm an interventional radiologist here at NYU. And I'm going to be talking a little bit about a procedure called uterine artery embolization or uterine fibroid embolization. That's one of the tools that we have to treat the symptoms of uterine fibroids. So uterine artery embolization is a minimally invasive procedure. It's done on an outpatient basis, and patients go home the same day. Small plastic beads are injected into the blood supply to the fibroids to slow and eliminate the blood flow to the fibroids. Once that blood flow to the fibroids is eliminated, the fibroids shrink in place and become deactivated, and the symptoms of the fibroids improve. The uterine artery embolization has a high success rate, short recovery, and low complication rate. The nice thing about a fibroid embolization is also that we can treat all fibroids in a single session. We don't target one or the other, but rather it's a global treatment of the entire uterus. And you can see in the pictures here, the picture on the left, you can see that the uterine volume shrunk over 6 months quite substantially, and we have about a 50% decreased volume of the uterine fibroids and the overall uterus, thus reducing the symptoms significantly of the fibroids. So the big question is, how does this impact fertility? So there are healthy, normal pregnancies and healthy babies after a uterine artery embolization. but we really don't know to what extent uterine artery embolization impacts fertility. There are small beads that are injected into the blood supply of the fibroids, and how that impacts the uterus and the placenta as a baby grows and thrives is not fully understood. There's not a tremendous amount of research on this topic. And so for that reason, we have to draw some implications based on the limited studies that we do have available on this topic. Uterine fibroids in and of themselves cause issues with fertility. And then the uterine artery embolization, which treats the fibroids, but then can impart fertility issues on our patients in its own right. So there can be some challenges with navigating what exactly is causing the fertility issue. Is it the fibroids, or is it the treatment for the fibroids? And so sometimes we're between a rock and a hard place with our fibroid patients on this topic. There are studies that look at how uterine artery embolization for the management of fibroids impacts fertility. This is a study that actually compared fibroids directly against myomectomy, which is removal of one or several fibroids while leaving the uterus in place. And so you can see here that 120 women were evaluated in this study, and they were put into two groups: uterine artery embolization, attempting to conceive, and myomectomy, attempting to conceive. And you can see in this purple chart the differences in the rates of pregnancy and labor and miscarriage among those two groups. And you can see that there is a substantially greater number of pregnancies among the myomectomy patients, higher number of labors, and lower miscarriage rates. And so when I counsel patients about uterine artery embolization, that comes into the discussion quite a bit. Would you be better off having a myomectomy? Is that an option for you? Is the anatomy good for a myomectomy? Or is a uterine artery embolization better than myomectomy because the anatomy is better for uterine artery embolization, or the patient specifically has needs where a uterine artery embolization is better than a myomectomy? So these are the kind of conversations that we have routinely when it comes to fertility when discussing embolization. This is another study that was published that actually looks at many different studies on this topic. And I've highlighted in red the number of patients who have gone on to become pregnant after uterine artery embolization. And so you can see that the numbers in parentheses are percentages. So there are routinely women who are getting pregnant after uterine artery embolization for management of fibroids. However, we do believe that there is an impact and that it does decrease fertility after uterine artery embolization. What you can't see from these numbers is how many people had any sort of other confounding issues that might make fertility difficult. So it's hard to draw hard and fast conclusions from a study as broad as this one. But when I look at all the studies together, and I've done a pretty thorough job of really looking at all of the research on this topic, when I consider all the studies and really put them together and try to draw conclusions about the role of uterine artery embolization and its effect on fertility, really, I do believe that there's an impact on fertility. I believe that there's normal, healthy babies that come after a uterine artery embolization, but it makes getting pregnant more difficult, and it makes having miscarriages more likely. It's not an absolute method of birth control. Certainly you can get pregnant after a uterine artery embolization, but there are definitely implications. And that's the most important thing for our patients to understand, is that it will likely impact their fertility. So ultimately, in the end, what does it matter for me if I'm the patient? And the reality is that we really look at each patient individually. So you can see an image on the left and an image on the right. The image on the left is a kind of fibroid that is almost external to the uterus itself. It has a look that you could almost just pluck it off of the top. Whereas the image on the right, you can see all those purple circles within the pink circle. Those are all the fibroids inside of the uterus. And these are two very different patients, and we're going to make very different recommendations based on the anatomy and the fertility desires of our patients. And so, whereas the picture on the left might be a better candidate for a myomectomy. The picture on the right is going to be a really difficult patient for myomectomy. And so that comes into the conversation when we're looking at how appropriate a uterine artery embolization is for a patient. And so ultimately, these are kind of patient by patient specific conversations.
Hi, I'm Dr. Tara Shirazian. I'm the director for the Center for Fibroid Care. And today I'm going to be speaking on radiofrequency ablation and the use of the transcervical fibroid ablation system known as Sonata. So as you can see here in this slide, the Sonata system has a few different pieces to it. It has an ultrasound that is placed in the uterus. So it's an intrauterine ultrasound that helps us visualize each independent fibroid. So it's a very targeted approach to each fibroid. After we identify the fibroid through the ultrasound, we place a probe into the center of the fibroid. These prongs come out of the probe and it allows us to create a sphere that's the dimension of the fibroid. Then we deploy the radiofrequency ablation. This ablation can be anywhere from 1 to 7 minutes. In this view, you see sort of all the markers on the right-hand side that show how we introduce the ultrasound. The image in the center is the uterus itself. The probe comes out, goes directly into the center of the fibroid, and we go ahead and deploy heat or radiofrequency ablation. Then the fibroid will slowly shrink over the course of 3 to 6 months. So it does take time. It's not an immediate process, but it's a non-invasive, targeted way to treat fibroids, help them shrink, that's non-surgical, and that can really temporize symptoms, especially heavy bleeding, bleeding in between periods, and also bulk symptoms related to the overall size of the fibroid. Again, here are some more images depicting how the system works. So we have the probe tip that comes out. The red is the ablation zone. You can see the various probes in the center of that fibroid. It has a green layer of a thermal safety border that helps us understand exactly where we are in the uterus so that the heat stays concentrated and targeted to the fibroid itself. The thermal safety border allows us to treat many fibroids and make sure that we're safe and in the myometrium of the uterus. And so this is a really great, safe way to treat fibroids that's extremely minimally invasive. So there are a few different studies now that have been done looking at radiofrequency ablation and fibroids. This study comes out of one of our big journals, one of our surgical journals called JMIG in 2022. And they looked across the board, a review of 405 publications, and they found 50 pregnancies in this study. And 40 of the pregnancies were after the laparoscopic radiofrequency ablation and 10 were after the transcervical radiofrequency ablation. And they found that the deliveries and the pregnancies post radiofrequency ablation went as well as the general population. There was no increase in preterm deliveries or postpartum hemorrhage or need for C-section. Since this study has been an even larger study of about 185 patients that basically has shown the same thing, that those 185 patients who underwent radiofrequency went on to have uncomplicated pregnancies, full-term vaginal deliveries for the most part, at the same rates as the general population. So meaning there was no difference in the group that had been treated with radiofrequency ablation versus the group that was not, in terms of OB outcomes and obstetric complications. So here's another study, another small study looking at 36 pregnancies, also showing that those outcomes after TFA were the same in those trying to get pregnant. So that in this study, they looked at things like spontaneous abortion, in those who were undergoing assisted reproductive techniques and early pregnancy loss. And they didn't find that there was any difference in the group had been treated with RFA. and then whether they had early spontaneous abortions or difficulty getting pregnant. So there did not seem to be a difference between those treated and the general population.
Hi guys, so we're going to be talking about fertility sparing surgery and fibroids. I'm Dr. Catherine Chan, and I'm a board certified minimally invasive fellowship trained GYN surgeon.
I'm Dr. Kelsey Kossel, and I am also a board certified and fellowship trained minimally invasive gynecologic surgeon.
So really, we're going to be talking about what are some symptoms associated with fibroids and what this looks like in terms of future fertility. So in the picture on the left, you can kind of see just a generic image of female reproductive organs. And then on the image on the right, you can see that it's magnified to show that there are different types of fibroids. And you can see that some of the fibroids can be within the inner layer of the uterus or in the outer muscle layer of the uterus. So when we talk about fibroid-related infertility, there are some theories that suggest and point to why fibroids can lead to infertility. So some of those reasons are that fibroids are surrounded by kind of inflammatory tissue that can impair receptivity of the endometrium. The endometrium is the inner lining of the uterus where an embryo or a fetus would implant. There is a thicker capsule or kind of like a rind around the fibroid that could potentially also contribute to this inflammation. Depending on the location of fibroids, it can actually distort the actual cavity itself. So when we talk about the cavity, we're really talking about that endometrium where the embryo would implant. It can also lead to increased contractility. The uterus is a big muscle, and sometimes having this inflammatory reaction can lead to the uterus contracting on its own. There are also kind of impairments in blood supply and blood flow to the uterus that could affect fertility, as well as some hormonal changes. So we're going to start our discussion on two different types of fibroids here. And that's going to be our pedunculated submucosal fibroid, which is the one that's hanging out within the inner lining of the uterus in the endometrium. And then our submucosal fibroids, which could be ranging from totally within the endometrium to partially within the endometrium, and then extending into the muscle layer of the uterus. In terms of submucosal fibroids, those are the fibroids that distort the cavity and have an impact on fertility. And in a relatively recent systematic review, patients with submucosal fibroids had statistically significant lower rates of clinical pregnancy, implantation, and ongoing pregnancy and live birth rates. Having submucosal fibroids is also associated with an increased risk of spontaneous abortion or miscarriage. So the first procedure we're going to talk about is your hysteroscopic myomectomy. So that's a fancy term for saying we're taking a camera as pictured here, introducing it into the vaginal canal, into the cervix, and then taking that camera and looking inside the endometrium. And that allows us to see and also treat at the same time and really resect and remove the fibroids that are impacting where an embryo needs to implant. So oftentimes we can do this in conjunction with other procedures. And what we're really hoping to achieve is to shave down and remove as much of the fibroid as possible, if not all of it, to really improve fertility outcomes and optimize that endometrium, that inner lining for implantation. Now, Dr. Kossel is going to talk about some other approaches to myomectomy.
Okay. So I think our stars might have moved here a little bit, but yeah, we're going to shift gears. So Dr. Chan was basically just going through a vaginal approach to removing fibroids. We can remove fibroids vaginally with the hysteroscopy technique when fibroids are small and when they're kind of either in the cavity of the uterus or in that submucosal location, kind of pushing into the cavity. When we have fibroids that are more within the muscular wall of the uterus, or as pictured at the top of the uterus, they are kind of what we call a subserosal fibroid, which is a fibroid that's actually more projecting towards the outside of the uterus, then we would be looking more at abdominal techniques to remove those fibroids. So Before we get into those techniques, I just wanted to talk about, Dr. Chan was just talking through, fibroids and how they might impact fertility. When we think they might impact fertility, we would then have some recommendations to go ahead and remove them to hopefully improve any fertility-related issues or complications of fibroids in pregnancy. So there is many papers kind of looking at them. This is actually one of the papers that comes from our Society for Reproductive Medicine, which is our main fertility society here. And this paper kind of came out with their general conclusions or recommendations and saying that there's fair evidence that myomectomy via either an open or laparoscopic route for those cavity distorting fibroids that Dr. Chan was talking about, or fibroids within the muscular wall that are coming up close to and touching the uterine lining, that removing those fibroids can improve pregnancy rates and reduce the risk of miscarriage. That's the reason why we do have recommendations for remove them. Many of these fibroids, when they're in that location, will also be causing women symptoms. So the main topic of this, talk tonight is about fibroids and fertility, but obviously we also take care of fibroids because they're the cause of bothersome symptoms for patients. So sometimes patients come to us with both fibroid symptoms, heavy bleeding, pain, pelvic pressure, and fertility concerns. So when we're thinking about surgery, we're thinking about doing surgery and improving those symptoms, as well as hopefully improving fertility rates and pregnancy outcomes. But there are actually some patients who may not have symptoms of fibroids and are just coming to us having discovered a fibroid while they're trying to conceive. And then there's a question of whether or not we should be doing a fibroid intervention for that person. This paper also touched on that and said that in asymptomatic women with, again, those cavity distorting fibroids, that myomectomy may be considered to improve pregnancy outcomes. So the verbiage is a little less strong here, where they're saying may be considered. And so this is a scenario where I really think there needs to be a big discussion between providers and patients in terms of deciding to be more prophylactic, removing fibroids before trying to conceive, before pregnancy, versus trying to conceive for some period of time and circling back to the idea of removing fibroids if someone finds that they're having a hard time conceiving, or is having miscarriage. So there's kind of a lot involved in that conversation. I think patient perspective is an important part of it. Some patients, just don't want to tolerate any risk of a potential miscarriage or potential adverse pregnancy outcome related to a fibroid. And since we can't quote the exact kind of risk or rate of that, they prefer to have the fibroids removed versus other patients might want to try to avoid surgery at all costs. And so that person might want to go ahead and try to become pregnant with the fibroid and again, circle back if they're having difficulty. The other things that we consider in this discussion, I would say, are patient age and other factors that might be impacting their fertility as well. So if we've made the decision to remove these fibroids and we do need to do it via more of an abdominal approach, then our two main options are to do a minimally invasive surgery or to do kind of a traditional large open incision. So when we can, we always prefer to do minimally invasive surgery. We do have studies that show that minimally invasive approach to surgery reduces recovery time, pain during recovery, and risks of surgery itself. Shorter hospital stays. For most of us, when we're doing these types of surgeries, our patients are coming and going same day from the hospital. And we typically quote them that they're feeling about 80 to 90% recovered by about 2 weeks after surgery. In terms of doing a laparoscopic or robotic myomectomy surgery, there are some factors involved in picking out who's an ideal candidate for that. There's not a one-size-fits-all rule here, but things that we're looking at are the number of fibroids. We want to make sure that we can do surgery efficiently and safely. When there's a tremendous number of fibroids, it may not be feasible or safe to remove that large number of fibroids with this minimally invasive approach. And the other thing we're looking at is comprehensiveness of surgery. So with either type of surgery, this is a major surgery that someone's undergoing, and we want to feel like we are removing as close to as many, of the fibroids as possible and not leaving a large amount of residual fibroids behind. Sometimes when women have a lot of small fibroids, for example, those are really hard to find and remove with a minimally invasive approach where we are just operating with use of our camera and then our preoperative imaging like an MRI to guide us. So for those patients who may not be a good candidate for minimally invasive surgery, then the alternative that we do is what's called an open myomectomy. And this is done with a traditional incision on the abdomen. The incision can often still be low and transverse, similar to a C-section incision. With this type of surgery, most patients are spending about 1, sometimes 2 nights with us in the hospital, and I would quote kind of surgical recuperation at closer to 4 to 6 weeks. With this route of surgery, the benefit is that we do get full access to the uterus in terms of actually being able to palpate or feel the uterine tissue. So even very small fibroids can be identified and removed in terms of being comprehensive when there's a large amount of fibroids or a lot of small fibroids within the uterus. And then one thing that I always like to talk to patients about when we're talking about myomectomy surgery is, we've been talking a lot about the benefits of removing fibroids ahead of pregnancy. But one impact of doing a myomectomy surgery on a future pregnancy is that most OBGYNs will recommend that a woman deliver via C-section if they've had one of these abdominal routes to their myomectomy surgery. So either the robotic myomectomy or a traditional kind of open myomectomy surgery. We are making incisions kind of into the muscular wall of the uterus and then taking some time to repair that muscular wall. And while we do a very good job repairing that muscular wall of the uterus, we do feel that there is some risk. There is a known association of that area of the uterus potentially rupturing or opening when a woman is undergoing the strong contractions involved in a vaginal delivery. So it's difficult to assess that exact risk. There was actually a large systematic review that was done that quoted that risk actually at about 1% of pregnancies after myomectomy might have a rupture of the uterus. But we think the theorized rate of rupture might be a little bit higher than that, closer to 2%. And that's just based off of some data that looks at the rate of rupture of women who have had a history of what's called a classical C-section incision, which is an incision on the uterus, kind of more in the deep muscular wall, which is similar to what we're doing with the myomectomy surgery. So many OBGYNs are just incredibly conservative and find that this 1 to 2% risk is higher than is tolerable and will recommend delivering via a scheduled cesarean delivery. The other thing to consider if we're talking about doing a fibroid removal surgery ahead of pregnancy is that most OBGYNs will recommend waiting about 3 to 6 months for the uterus to heal after the fibroid removal surgery before trying to get pregnant.
Thank you for joining us today for our Fibroids and Fertility webinar. We hope that we've answered a lot of your questions regarding the various procedures and fibroids and kind of what to expect with fertility after you've done a lot of these procedures. Please come and visit us at the Center for Fibroid Care here at East 53rd Street. We are all here to see you and to help. We consider ourselves your fibroid home, and we hope that we will continue to answer any questions that you have and that we can help serve your needs. Thanks so much.